So why do we even need to talk about meniscus repair? So this is an image of a fairly young former football player, and you see on the left-hand side his meniscus torn. He had a little bit of cartilage degeneration already here, grade 2, but 6 years after a complete meniscectomy, you can see what happened to his knee. So there is no cartilage left. He has osteoarthritis, and we want to prevent this actually, and that's why we have to talk about it. We all know, or you know, that the menisci are important structures to transmit load through the knee joint, so especially close to extension, and in that case they act like a shock absorber. And most interestingly, the compressive load that are acting on the knee joint are transformed into circumferential tensile hoop stress, which provides also stability to the joint despite nutrition and proprioception. And as we all know, the knee is not really congruent, and what the menisci do, they kind of fill this incongruency, as you can see here, and they extend the tibiofemoral contact area by therefore decreasing the transmitted load. So what happens if we have to remove one of the menisci? So this is a graph showing on the very right-hand side what happens if we actually remove the meniscus. So if we have, for example, a meniscal root tear, which we commonly see in osteoarthritic knees, it equals a complete meniscectomy. So and the load increases exponentially, and then osteoarthritis will progress rapidly. So we have to avoid these. And many years ago, everyone was saying, okay, if you have a medial meniscus root tear in arthritic knees, don't repair it, just leave it alone. But we know it's a bad idea, actually. But we come back to that later. So, and what are the risk factors when facing a meniscus tear with regards to progression to osteoarthritis? And actually, if we have signs of meniscus extrusion on MRI or even ultrasound, or if we have complete radial tears or complex tears, the likelihood of early onset osteoarthritis is pretty high. So the question now is, what are the perfect indications for meniscus repair? As we know, the tissue quality sometimes is not as good as we wanted to have it. So we need to find the right patient for our treatment. And ideally, we have all young soccer players, but as we know, there's a lot of diversity. And we have some skinny people, we have people with a higher BMI, we have tall people, we have short people, we have women, we have male. So we have to face all these facts. And the question is now how to do it clinically. And we have to look at all these factors. So there are many factors we have to look at when repairing a meniscus. And the most important thing is, when looking at literature or even in clinic, don't compare apples with oranges. You can do it as shown in this study, but it's not a good idea. So let's start with age. Usually everyone is saying age is a contraindication for a meniscus repair, as we know that the tissue quality is basically deteriorating, the content of water within the meniscus is going down, and even the vascularity is limited in elderly people. So the meniscus repair won't heal. That's what everyone is saying. But let's see what happens if we do actually repair in people with moderate osteoarthritis in their 40s, 50s, and 60s. And actually, there's a systematic reviews who looked at partial meniscectomy, and of course, there was no significant difference. But what happens if we repair it actually? And this is what you can see: 87% success rate if you do a meniscus repair in patients between 40 and 60 years of age. So this is a number. 87% success rate is good. And so whenever we are facing patients with meniscus tears, we shouldn't really look only at the age, but look at their demands. Are they active? How are they biologically, are they biologically younger or older? So if they are younger, we should, if possible, aim for a meniscus repair. And in fact, this study here, it's easy to summarize. So if you look at different age groups between 25 and 40 and so on, there's no significant influence on patient-reported outcomes. So the age, at least until the age of 50, has no significant influence. So what about the BMI and the lifestyle of and habits of the patients? So there are conflicting results with regards to the BMI. However, the higher the BMI, the higher the transmitted load through the joint. And so we should avoid any excess loading to a meniscus repair. So we don't recommend doing any meniscus repair in patients with a BMI above 30. And as we all know, smoking habits reduce the capability to a tissue to heal. So even look at this. So don't try to do a meniscus repair in patients in their 40s that are smoking. It won't work. So what about their location? We know that the blood supply is decreasing from the periphery, so the capsule, to the inner part of the joint. But is it really important? And I would say no, not really. So of course, the success rate of a meniscus repair is higher the closer that there is to the capsule. However, we also have in this middle age group, so in their 40s, we have a fairly high success rate, even if you perform a repair in the red-white zone. So I wouldn't only consider doing a repair in the red zone. And so it's more, as said before, look at the age of the patient, look at their biology, look on their smoking habits. It's more important than actually their location. So this is now most important because we know in degenerative knees, and there are some tear types that are commonly seen. For example, tears that we face actually clinically. We know that when you are having a radial tear, it equals a complete meniscectomy. So it would change the kinematics, it will change the contact forces, even if the tears are small. But if the tears are basically going through the meniscus, you have to repair it to avoid any early onset osteoarthritis. So how do we treat these patients? This is one example. We can do a side-by-side repair if it's possible, but frequently, for example, on radial tears that are close to the posterior meniscal root, so it's not possible to perform a good root repair. So in these cases, we do a transtibial pullout repair whenever possible. Of course, even if the tear extends into the compartment. So if the tear is short, we move our bone socket, our bone tunnel a little bit more medially, and that helps us to at least prevent or preserve as much tissue as possible. So whenever we face a meniscal root tear on the medial side, even in a moderate osteoarthritis, we go for a transtibial pull-out repair. We don't do it in end-stage osteoarthritis, of course. So what about the horizontal cleavage tears that we see on almost every patient in their 40s or 50s? We know that these tears don't really affect our kinematics and our contact pressures. However, if we have very huge tears extending from anterior to posterior that we rarely see, we know that also the contact pressure could be affected, but I don't think it's clinically relevant. But what about chronic tears or degenerative tears? We know that the earlier we do a repair, the better it is for the outcome of the patients. However, time is not an exclusion criterion for a repair. So even if it's chronic tears that are at least 2 or 3 months old, we try to repair it. However, we need to enhance the biology. So what you can do, for example, a microfracturing in the intercondylar notch to kind of mobilize some stem cells or precursor cells, you can go in with a small rasp and try to rasp on your synovium, and just to mobilize some cells and to induce some bleeding, actually. Most important thing is stability and alignment, in my opinion, especially in patients with moderate osteoarthritis. So we know that the menisci help to stabilize the knees. So for AP translation, the medial meniscus is important. For rotatory instability, the lateral meniscus is important. So whenever you're facing an unstable knee with a meniscus tear, it's useless to do a repair on the meniscus if you don't fix your ligaments. It won't heal. It's simple. So, but what to do with patients that have a mild varus, for example, 5 or 6 degrees? If you are facing patients with early osteoarthritis or moderate osteoarthritis with meniscus-related symptoms, I recommend you to perform a long leg standing radiograph to look at the axis, because the patients won't do well if you just do some sort of meniscus repair or debridement whatsoever, if you're not really correcting their malalignment. So we always look at the coronal alignment. If the patient have excess varus or valgus alignment, we highly recommend to realign first the leg before the meniscus is repaired or debrided. So when we now look on our patients between 50 and 90 years of age, about 45% or even more have evidence for a meniscus injury if they are if they go to have an MRI. However, only 1/3 of them really have symptoms. So the question is, do we really treat meniscus tears in this age group with moderate osteoarthritis? And that's what evidence is saying is no. So there is no indication to perform just a meniscus debridement in degenerative meniscus tears in subjects with early and moderate osteoarthritis. However, when reading the articles carefully, there are some points that should be considered. So, first of all, what were their indications for treatment? And their indications usually are based on MRI. The authors of these articles, they didn't look on symptoms like locking, effusion, pain, and so on. They just looked at the MRI and defined, okay, physical therapy or operative treatment, and they found no significant difference. But when following the patients longer, about half of the patients got subsequent meniscus surgery after they opted for a initial conservative treatment. So follow your patients and you will see that many of these that are symptomatic need actually a meniscus injury. However, we need to have kind of a guideline. And this is the ESCA consensus meeting that we published a couple of years ago. And in fact, whenever you're facing patients with early and moderate osteoarthritis in their 40s and 50s, and if they are present with meniscus related symptoms, just leave the meniscus alone. Treat them conservatively, proper physical therapy, motion training. You can, the most important thing is to keep the patients active. If your conservative treatment fails after 3 to 4 months, you can opt for a surgical treatment like debridement and so on. However, whenever facing patients with meniscus injuries or meniscus symptoms, look on symptoms like locking and effusion. If the patient continued to suffer from locking periods, I would opt for early surgery. If they don't have any locking, I wouldn't opt for any surgery at all. So what's the ideal indication? The best patient has no meniscus tear, which is not realistic, as we know that half of us have already meniscus tears. So in early phases or traumatic cases, we need to save the meniscus, and we need to fix what is torn, regardless the age, regardless the degeneration status of the knee, at least if it's not an end stage osteoarthritis. In degenerative knees, in osteoarthritis knees, look at mechanical symptoms. Pain is not a strong indicator, but also look at the lower limb. The most important thing is looking at the lower limb to realign the patients if they have symptoms. The patient would benefit the most from the realignment surgery rather than meniscus surgery. So thank you very much.